Hey there, I'm Dr. Shannon Gregoire, and I want to welcome you to another episode of Vet Candy Rounds. Today, we're working on the case of the hyperglycemic spaniel. Let's get into it. All right, so today's case revolves around George, a 10-year-old Springer Spaniel. He's been dealing with some hind limb weakness just today. He has a history of chronic renal issues and has been on a strict renal diet, but has otherwise been healthy. The owner just noticed these symptoms today. First up, let's do a physical exam. During the checkup, we're noticing some concerning signs. George's gums are looking pale and sticky. His breathing is rapid and his heart rate is through the roof, although the rhythm seems normal. Lungs are clear. Abdomen isn't tender, but we are feeling something in there that may be a mass. Plus, George has weakness in the back end when lifted, though he's still responsive. Neuro Exam time reveals some sluggishness and back leg withdrawal, but pulses seem fine. Reflexes, on the other hand, not so great. At least George can feel pain. And now, he's laterally recumbent. So, what's the plan of action here? Let's weigh our options and decide on our next move. First things first, let's stabilize George, give him some fluids, and dive into those diagnostics. Here are the results we've got to work with. Hematocrit, 24%. Yep, we've got ourselves some anemia. Azotemia is also in the mix, with a BUN of 40, creatinine of 4.4. George is also rocking some hypercalcemia and hyperphosphatemia, and his pH is sitting at a cool 7. Acidic vibes, anyone? Your analysis is looking good, but blood glucose skyrocketing at over 600. Ultrasound reveals a little something in George's mid-caudal abdomen, measuring 6 to 9 centimeters. Now, let's check on the patient. George seems to perk up after the fluid boost and is walking around. Wow, this is a puzzling case. I think it's time to call in a specialist. Let's reach out to Dr. Kristin Welch, a veterinary criticalist, to help us navigate this bizarre situation.
Thank you for reaching out to DVM Stat for this stat chat. I'm Kristin Welch, I'm a criticalist, and I'd love to try to help you with this case. It's a really interesting one. So your patient is significantly hypovolemic, and you've been addressing that really well with the fluid therapy that the patient's been receiving. In calculating the total volume of fluids that he's gotten so far, it's about 30 mils per kg, and shock dose in dogs is 90 mils per kg. So your patient's gotten about a third of the shock dose. He's still tachycardic, but it's improved. His perfusion parameters are better, and now he's up and walking around, which is great. But in looking at the lactates that were sent over, the patient still has a persistently elevated blood lactate level. And there's two different types of lactate. There's type A lactic acidosis, which is the type that we see with hypovolemia and decreased perfusion from situations like anemia. And then there's type B lactic acidosis that we see in cases of neoplasia or certain metabolic or toxic conditions. In this patient, I suspect that this is a type A lactic acidosis, and I would imagine that as we continue forward with fluid therapy and try to maximize our euvolemia, that as we track the lactate over the next 2 to 4 hours, it should return to normal, which is the lactate clearance. And we want to prove that that's the case to know that this is a hypovolemic induced type A lactic acidosis. So volume-wise, I think I would try to give another crystalloid bolus in this case. And we have two choices for crystalloid bolus. Right now, the patient's been on just plain crystalloids like LRS or Phyllite and has received about 30 mils per kg. A bolus of hypertonic saline for small volume fluid resuscitation would make sense at this point. Typically a 3 to 5 mil per kg bolus, slowly over 15 to 20 minutes, would allow us to be able to rapidly volume expand the patient with a small volume of fluids and to recruit a lot of that interstitial fluid that the patient has to maximize volume expansion. During that time, I would keep him on a crystalloid CRI, probably at maybe twice maintenance, and see how his heart rate responds, how the lactate responds, and to continue to monitor this PCV in total solids. The other concern that we have in this case is, why was that blood glucose well over 500, but yet with no specific intervention, it's come down into the 100s. And there's really only a couple situations where I've seen that occur before. One of the more common is a severe catecholamine surge. So part of the flight or flight response is going to be a massive surge of catecholamines, and we'll see that with things like adrenal tumors. And the catecholamine surge can cause a glucose to shoot up well into the 400 to 500s and sometimes even above. And unlike situations where you have a persistent ongoing glucose stimulus, where the glucose won't come down on its own, with a catecholamine surge, as soon as the catecholamine surge stops, the glucose tends to drop on its own back towards normal, which is very similar to what happened in this patient so far. And so that has to be at the top of our differential list, is could this patient have had some kind of a catecholamine surge? The other thing that makes me concerned about that is the fact that his peripheral perfusion parameters on initial presentation were markedly abnormal. He was sheet white in his mucous membranes, really poorly perfused, and laterally recumbent with a severe tachycardia. So for that reason, I think we need to have that as one of our main differentials. I would continue to track this glucose though really carefully, probably every 4 hours or so over the next 24 hours, just to make sure that two things don't happen. One, to make sure that the glucose doesn't shoot back up, which might happen. And if it does, then a catecholamine surge probably isn't the cause of this hyperglycemia. The other is to make sure that what we don't see is actually a rebound hypoglycemia. So anytime the glucose becomes elevated, you get an insulin surge. And with a glucose that was above 500, you might have a huge insulin surge. And so we want to track and make sure that the patient doesn't become hypoglycemic and actually require dextrose supplementation temporarily. Assuming that the glucose continues to remain normal for 24 hours, we're probably out of the risk zone for a rebound hypoglycemia, and you can probably decrease your glucose monitoring interval at that point in time. The other thing that we need to keep in mind in this patient is this patient has a really severe lactic acidosis, and lactic acidosis helps to contribute to some other metabolic derangements as well. And so part of tracking your response to fluids is going to be to continue to monitor for resolution of the hypo or of the tachycardia, and also resolution of this patient's lactic acidosis. But what I'd like to also make sure that we're monitoring is this venous blood gas, whether it's in the form of an iStat or some other monitor. The venous blood gas will allow us to keep track of the patient's electrolytes. The electrolyte abnormalities initially in this dog were pretty mild. There was a mildly low sodium and a very mildly elevated potassium. And I would suspect that those changes were probably related mostly to the small to moderate volume of effusion that was in the abdomen, because we'll see that quite often. And fortunately, this patient had a baseline cortisol completed at the time of their initial minimum database, which showed elevated results. So completely ruling out the potential for hypoadrenocorticism. The ongoing neuro status evaluation should probably be continued every 2 to 4 hours as well, moving forward, along with the blood pressure every 2 to 4 hours, to make sure that we are consistently keeping track of this patient's ongoing improvements, and if there is any downslide in our progressive improvement, that we halt and kind of reassess the situation, because this is a really dynamic case. Thank you for having DVM Stat Consulting on today. This was such an interesting case. Learn more about DVM Stat Consulting at www.dvmstat.com. Thanks again.
Wow, incredible feedback from Dr. Welch. Having experts help us on a case like this is always helpful. That's it for the show. Thanks for tuning in to Vet Candy Rounds. If you dug this episode, don't keep it to yourself. Share the love with your friends. See you next time.
When you talk to clients about parasites, recommend this parasiticide from Boehringer Ingelheim Animal Health. NexGard Plus is the one you want for one and done monthly protection. It prevents heartworm disease, kills fleas and ticks, and treats and controls roundworms and hookworms. Plus, the delicious beef-flavored soft chew is safe for puppies. Use with caution in dogs with a history of seizures or neurologic disorders. Give your clients one and done monthly protection with NexGard Plus.